Hello everyone, Lauren Bean here. This is a lecture over chapter 13, which covers the peripheral nervous system. For the peripheral nervous system, there are several divisions and ways to organize it. The first is into a sensory afferent division and a motor efferent division. From there, it can be further divided into the somatic nervous system and the autonomic nervous system. So with somatic, we're thinking about voluntary motor control, so our motor neurons innervating skeletal muscle cells. In contrast to the autonomic nervous system, this is involuntary motor nerve fibers innervating our smooth muscle, cardiac muscle, and glands. For the ANS, it's divided into the sympathetic and parasympathetic division. So this whole branch here is the topic of chapter 14. The peripheral nervous system is everything to the sides of the central nervous system. So, really, just all neural structures except for the brain and spinal cord. So, it includes sensory receptors, sensory nerve fibers, motor nerve fibers, ganglia, which are collection of neuron cell bodies, as well as structures called motor endings at the neuromuscular junctions. Sensory receptors are specialized dendritic endings, right? Because the dendrite is the input region, and they respond to stimuli or changes within our environment. Receptors are either detecting general senses or special senses, so that's a major way in which we divide our senses. Chapter 15, we're going to go in detail over these special senses. This chapter, we're primarily focusing on general senses, so things like touch, temperature, pain, etc. Activation of our sensory receptors. So, when a stimulus it activates a receptor, it's causing a graded potential, a localized change in the membrane potential. And if that stimulus is intense enough, it's going to generate action potentials or nerve impulses that's going to transmit that information along a sensory neuron to the spinal cord and up to the brain. So, this sensory information travels along afferent pathways to the central nervous system. And it's the brain that is responsible for sensory perception. Most of that sensory input travels to the somatosensory cortex, but some of that sensory information will go to other areas of the brain as well, maybe just to the cerebellum. So, all afferent pathways are carrying sensory information up to the central nervous system. For sensory receptor classification, we can talk about it in terms of the stimulus in which they detect, or we can classify by body location. And then third is structural complexity. So they're categorized as either encapsulated or non encapsulated, aka free nerve endings. For a classification based on stimulus type, we have mechanoreceptors responding to mechanical forces, touch, pressure, vibration, stretch. Thermoreceptors, of course, are detecting temperature changes. Photoreceptors, these are specialized cells called rods and cones within the retina of our eye. They can detect different wavelengths of light and produce vision for us. Chemoreceptors react to chemical stimuli, and those chemicals could be things like pH level, could be carbon dioxide level, or also the odorants responsible for producing olfaction or a sense of smell, as well as chemicals within our food that bind to taste buds on our tongue and create a sense of gustation or taste. So there's quite a bit of variability there with the chemoreceptors. Then we have our nociceptors, which detect pain. So they're responding to either extreme temperatures, mechanical damage, even chemical irritants. There's a lot of different types of stimuli that can lead to pain, and these are even activated in prediction of pain as well, or potentially harmful stimuli can activate the nociceptors. Classification of sensory receptors based on location. We have exteroreceptors responding to stimuli from outside the body, going to be found, near the body's surface to be able to detect that. So embedded within our skin, responding to a lot of tactile mechanical sensations, but also include our special senses as well. So vision, hearing, equilibrium, smell, taste, and that will be the topic of chapter 15. Interoreceptors or visceroreceptors, visceral means inner. This responds to stimuli from internal visceral organs, and that can create a sensation on either a conscious or a subconscious level. Like we can be consciously aware of the sensations of pain in the GI tract, nausea, hunger, thirst. But then there's a lot of subconscious sensory information traveling to the central nervous system as well that we are not at all aware of. Then we have our proprioceptors, and these inform the brain of our body's position in space, our body movements, monitor the degree of stretch in our skeletal muscles, monitor sensations in our joints, our tendons, really give the brain a sense of body space. So, this table summarizes the difference between our general senses and special senses. The general are all throughout the body, widespread sensory receptors, fairly basic receptors as well in terms of the dendritic endings. Type of stimuli includes touch, temperature, pain, and proprioception. Versus our special senses, these are found in complex sense organs and localized in the head, so eyes, ears, nose, and mouth. The receptor types are much more complex and specialized, a lot more, accessory structures or accessory cells involved here. And the stimuli includes vision, hearing, balance, taste, and smell. This chapter, we're just focusing on our general senses. So they're listed again here for you. Another name for touch is tactile sensations. So that includes multiple things, not just simple touch, but also thinking about pressure, skin stretch, vibration as it penetrates through the body. We'll talk about those different types of touch in more detail. We can classify these as either non encapsulated free nerve endings or encapsulated. Those that are encapsulated are surrounded by a connective tissue capsule. So just more, tissue, more connective tissue being associated with those dendritic endings versus the free ones. It's just, raw exposed dendrites. We're going to talk about these specific types here that are listed as examples under each of these categories. And we're going to go in detail about each of those. All sensory receptors undergo adaptation, and this refers to how a sensory receptor becomes less responsive to a constant stimulus over time. So it's like tuning out this ongoing continuous stimulation. And this is really important because it allows the brain to focus on new or more relevant information that's coming into the brain. And when we talk about adaptation of the sensory receptors, we can categorize it as fast or slow. So, phasic receptors, they're fast adapting, they phase out quickly. So, with this image here on the right, we're looking at these lines, which are representing action potentials coming from the sensory receptor. And when a stimulus is first applied, that phasic receptor will be activated. It's going to send action potentials. But if that stimulus, is staying and is constant, we're going to see that it quickly kind of phases out. And when that stimulus is withdrawn, there will be an action potential sent at that ending point, right? So it's really important for detection at the beginning and the end of stimulus application, right? But it really tunes out that intermediate area. Tonic receptors are more slow adapting. So I said that they kind of maintain a constant tone. The action potential frequency stays pretty much the same. So it's really not phasing out. And this is more ideal for continuous monitoring. So things like continuous pressure, continuous stretch, things that we really need to be more aware of in contrast to the phasic receptors. And then with the nociceptors, these are really non adapting. And this is important because we want that message of pain to be continuously sent to encourage us to remove the painful stimulus or, to do something and respond to potential injury. So here we have our non-encapsulated free nerve endings. And when we think of visual of that, it's really just free exposed dendrites embedded in the skin, embedded within connective tissues. So they're pretty simple. They can even be unmyelinated or lightly myelinated. So they're lacking an extra connective tissue sheath around those dendritic branches. So these are very common, widely distributed all throughout. They're innervated by group C fibers. So those are really slow fibers in terms of action potential conduction to the central nervous system. So it's like, this information does need to make its way to the spinal cord and brain, but, it's going to travel relatively slow compared to other information. So this includes our pain receptors, thermal receptors, tactile or Merkel discs, as well as hair follicle receptors. Down below here, I have a little bit more information about those nociceptors. So they're stimulated by extreme temperature, pinching mechanical forces, or even chemical stimuli such as inflammatory chemicals. And these receptors have a certain vanilloid pain receptor component. This is an ion channel that opens up in response to pain, which leads to depolarization, action potentials, and the release of substance P from these neurons to transmit that pain impulse to the brain. All right, you got to remember that substance P is that special neurotransmitter involved with sending information about pain, right? P for pain. With our thermal receptors, we have both cold and warm receptors that are sensitive to certain temperature ranges. Any temperature outside that range is perceived as pain. So there are pain receptors, cold pain, hot pain, that detect the extreme temperatures and generate that painful sensation. So when we look at this graph down below, we have temperature on the x-axis, impulse per second action potential generation on the y-axis. This solid blue line represents the temperatures in which our cold receptors are activated. But then there's this transition point here with our dotted blue line representing cold pain. So at this point of crossover, about 10 degrees Celsius, really getting at that pivot point of where a sensation no longer feels cold, it starts to become painful. Similarly, with our warm receptors and heat pain receptors. So, in the dotted line being that range in which a warm sensation is felt, here's our crossing over point here at about 45 ish, 50 degrees Celsius, in which heat starts to become painful. So, there's really like 4 different receptors involved here with sensing temperature. There are different types of touch or tactile sensations. We can classify it as crude touch, light touch, fine or discriminative touch, and then deep pressure. And each is really important and plays a particular role. But we also have to keep in mind that several receptors will be activated all at the same time. So touch is extremely complex. With crude touch, this provides, very vague information about an object's presence, but it lacks really all detail. So we can say that it is non-discriminative. We can't exactly, figure out maybe what the object is that we just say, bumped into, right? Or it can be broad pressure that we feel on the body, such as like wearing a backpack, and even like the feeling of clothes on our skin. It's pretty non discriminative, but we know that the object is there. Light touch is very gentle, superficial contact with the skin. So if you were to take a feather, and brush it lightly across the skin, a feeling of maybe even breeze on your skin, that really light, subtle contact. Then fine discriminative touch is one of the most important because it provides really high detailed information about an object's shape, size, texture, provides very high precision tactile discrimination. So sometimes it will even be 2-point discriminative touch. That's how it is described. And this really enables diagnosis, the ability to identify an object by touch without any visual stimulus. So if I were to tell you, close your eyes and I just put an object within your hand, and you start to feel it, if you can identify what that is, you're using fine discriminative touch to carry out that diagnosis. Then lastly here, deep pressure, which is intense, sustained force. So you're activating, receptors in deeper layers of the skin. When someone, squeezes your hand really firmly during a handshake, or you're getting a deep tissue massage, you're sitting firmly in a chair for a long period of time, right? That applies deep pressure to the skin. Our other two receptors, which are free, non encapsulated nerve endings, include tactile Merkel discs as well as hair follicle receptors. So, with the tactile Merkel discs, these are found in the stratum basale of the epidermis. And that's the transition point we're looking at here. So, very superficial in the skin, detect really light touch, also playing a role in fine discriminative touch. And is going to be abundant in areas that are very sensitive on the body, so like our fingertips, even our lips. And with this complex here, there's a tactile epithelial cell, so like a modified epithelial cell that interacts with this modified dendritic area called a Merkel disc. But there's no connective tissue sheath here, so it's still a free nerve ending. But as you can see from the visual, it's an interaction of a modified epithelial cell and a dendritic ending. With the hair follicle receptors, these are wrapped right around the base of a hair, right around the hair follicle itself. So it can detect light touch due to the deflection of hair. So if anything is going across the surface of our skin, bends that hair, it's going to activate those hair follicle receptors. These are pretty fast adapting, making them really only responsive to changes in the environment, right? Or, if a bug starts to all of a sudden crawl up our leg or arm, we might feel that initial movement, but they do phase out. And that can make it really tricky to identify things such as like ticks that are going to hang out on your skin for a longer period of time. So these are activated, when we do feel, breeze move across the skin and maybe activate even our goosebumps. Movement of crawling insects, gentle stroking of the skin is going to activate these hair follicle receptors. Now moving to our encapsulated dendritic nerve endings. This includes tactile or Meissner corpuscles. These are critical for fine discriminative touch, provide really high detailed precision, inform us of an object shape, size, texture. So I described that on the previous page, right? These are located in the dermal papillae, so really at that transition of epidermis to dermis in the papillary layer. Very abundant in our fingertips, palms, sole of our feet, lips, eyelids, face. So really, really sensitive areas that can sense very precise touch. Then our lamellar or Pacinian corpuscles are detecting deep pressure and high frequency vibration. The name lamellar comes from the fact that the ending of this dendrite is wrapped in collagen fibers, making it kind of look like an onion or a layered structure, hence lamellar corpuscle. So when we have sensations like, feeling vibration from a power tool, like an impact, a driver, a drill, right? Sawzall, anything like that, that really vibrating force penetrating through our skin, we're activating these lamellar Pacinian corpuscles. Even that firm pressure from sitting in a chair long term, right? Really activating those examples I mentioned correlating with deep pressure. Other examples of encapsulated dendritic nerve endings, we have Ruffini endings or Ruffini corpuscles. These are sensitive to skin stretch along with deep pressure and sustained touch. But skin stretch in particular, especially when our skin's being pulled abnormally, right? If someone were to, like, tug on your skin, any kind of tearing, pulling force is going to activate these receptors. So they're pretty slow adapting. This is information we want to be aware of to protect the skin and underlying connective tissues. Another critical area in which they're found is in the joint capsules, providing proprioception information to the CNS. These other three here are also functioning as proprioceptors. So you have muscle spindles, which are found in the muscle itself. It's a modified region within the muscle that is sensitive to muscle stretch. So, always sending that information to the brain about the state of our muscle. Is it relaxed? Is it stretched? Is it ready to go? Or does it need, some more activation? It also has a protective function, so it can trigger a reflex, causing an excessive stretch muscle to contract and to prevent tearing of that muscle. So when we think of like a knee jerk reflex, that is activated by the muscle spindle. Golgi tendon organs, these are within tendons, really at the transition between muscle to tendon. These are also responsive to detecting stretch in the tendon and can trigger reflexes that cause a stretched muscle to relax and prevent tearing of tendons. So these work in a similar manner, but the location is different and the overall effect is a little bit different, but it can activate that protective reflexive activity. Then with our joint kinesthetic receptors, there's several different types, but these are within the joint capsule, monitoring joint position, can even monitor things like inflammation within the joint, but has all to do with movement within the joint. So now that we've talked about sensory receptors, the dendritic endings, we need to consider the nerves, the long bundle of axons which transmit this information to and from the CNS. Right? So we're using a different term now. We're not referring to it as a tract, we're saying it's a nerve, a bundle of long axons in the PNS. And when we look at a nerve, there are different connective tissue coverings and there's different bundles. Covering the entire nerve is an epineurium. This is a tough fibrous sheath encasing, protecting the nerve. Within, there are fascicles or bundles of many, many axons. Each fascicle is wrapped in a perineurium. And then each axon itself is wrapped in an endoneurium, a looser connective tissue which encloses the axon and its myelin sheath. So there's many connective tissue coverings here. We're going to start by looking at the cranial nerves, and then we will get to the spinal nerves toward the end. We have 12 pairs, so each has its own name, but also indicated by Roman numeral. Some of them are originating and sending information directly to brain structures. Others are originating from the brain stem. And they innervate the head and neck. And then the vagus nerve is a unique one because it extends beyond the head and neck and innervates the thoracic and abdominal organs. So we have the olfactory nerve here, optic nerve, oculomotor nerve, trochlear nerve, trigeminal, abducens, facial, vestibulocochlear nerve, glossopharyngeal, vagus, accessory, and hypoglossal. I'm not going to expect you to remember the Roman numeral for each. I just don't really find that fair. You don't have to remember them, in order, but I want you to understand the function of each. With cranial nerve number 1, this is the olfactory nerve, has to do with olfaction, our sense of smell, and it's a purely sensory nerve, right? There's no motor innervation going on here. The pathway begins with olfactory sensory neurons within the superior nasal cavity. These neurons travel through the cribriform plate of the ethmoid bone. It looks like a cribbage board with a bunch of little holes. So, as we inhale, odorant molecules bind to these sensory neurons, generate action potentials, synapse with mitral cells and the olfactory bulb. That information is carried along the olfactory cortex or the tract to the primary olfactory cortex for interpretation. If there's any damage to these neurons, damage to the ethmoid bone, it can result in anosmia, a loss of sense of smell. That can really decrease quality of life. It can even put people in a harmful situation because they're not going to be able to smell smoke, smell a gas leak. They're not going to be as aware of their surroundings. So it can be a pretty serious issue. Cranial nerve 2 is the optic nerve, also purely sensory, carrying afferent impulses for vision. Afferent meaning sensory, afferent meaning traveling to the brain. So there is an optic nerve, right? A pair of them innervating each eye. The optic nerves cross over. Most of the fibers within the optic nerve cross over at the optic chiasma. After that crossing over, it forms the optic tracts at that point. Those fibers then synapse in the lateral geniculate nucleus of the thalamus. Thalamic neurons from there form the optic radiation, right? Those fibers literally radiate out and project to the primary visual cortex within the occipital lobe. And that's the area that's going to receive the information, then link to the association areas for interpretation. Cranial nerve 3, the oculomotor nerve. As the name implies, it is a motor nerve innervating the eye. And there are a few critical functions here. Innervates 4 of the 6 extrinsic or extraocular eye muscles for precise, rapid control of the eyeball and directing its movement. Also innervates the levator palpebrae muscle, which causes our upper eyelid to raise. And then it also has autonomic motor fibers going and innervating the lens of the eye, controlling its shape for visual focusing. Whether we're looking at something close up or far away, the lens has to change shape. And again, oculomotor nerve here is going to stimulate it to change shape. And it also plays a role in the constriction of the pupil, either dilating it to allow in more light or constricting it to reduce the light input. With the pupillary light reflex, when you shine a light onto an individual's eye, the pupil should constrict in response to that bright light. The sensory input there, of course, is traveling through the optic nerve, but there is connections to the oculomotor nerve, which are automatically going to cause constriction of the pupil to reduce the amount of light coming in to the eye. So that is an automatic thing, a reflexive thing that happens. So there's direct, communication between the optic nerve to an interneuron to the oculomotor nerve. So if everything is good within that reflex circuit, if the oculomotor nerve is healthy, you're going to have constriction of the pupil like that. The oculomotor nerve also controls the shape of the lens for focusing, as I mentioned. So the lens is found in our eye. So we have the cornea, which is the outer transparent layer protecting the eye. Okay, then deep to it is some fluid, eventually getting to the lens inside there. When we're looking at things that are further away, 20 feet and beyond, distant vision, the lens is more flat and thin versus when we're looking at something close up, so like we're reading, something like that, the lens is thicker, it's fatter, has more of a curve to it. So the lens has to change shape or accommodate for that near vision. And the manipulation of the lens is due to control by the oculomotor nerve. Then we have the trochlear nerve. This innervates the superior oblique muscle of the eye. The name of it comes from the fact that this muscle travels through a cartilaginous loop called the trochlea, which looks pulley-like or it's pulley-shaped. The term trochlea means pulley. So kind of a unique scenario here in which, this cranial nerve is just innervating one particular muscle of the eye. This muscle moves the eye inferiorly and laterally, so down into the side. So there's precise control of that motion. Then we have the trigeminal nerve, tri meaning 3 because there are 3 divisions which make it up. This is the largest cranial nerve, and it happens to be mixed, meaning it's involved with sensory and motor. So the 3 divisions, we have the ophthalmic maxillary mandible. This colored image here shows you those 3 areas of innervation. For sensory neurons, It's innervating the face to transmit touch, temperature, and pain. So, kind of our basic general sensory information. For motor innervation, it's only the mandibular division, so our lower division here, the jaw, that is going to contain motor fibers innervating the muscles of mastication. So the muscles involved with chewing, our temporalis muscle, masseter muscle, pterygoid muscles. Right? So all of the chewing that occurs there, those motor fibers passing through the trigeminal nerve, innervating the muscles within that mandibular division. The abducens nerve is a motor nerve that innervates the lateral rectus muscle of the eye. This moves the eye laterally, hence its name. So, another nerve with just kind of that unique innervation to one particular eye muscle. The facial nerve, this is a mixed nerve, so has motor and sensory innervation, but is primarily motor in its function. There are 5 branches, so you can see here a simple way to remember this. So you can overlay the hand onto the face. So there's temporal, zygomatic, buccal, mandibular, and a cervical branch of the facial nerve. Somatic motor innervation to the muscles of the face produce our voluntary facial expression, right? We have control of that. Then for autonomic motor innervation, it's going to innervate the lacrimal glands, so our tear glands, nasal glands, and the nose, salivary glands to produce saliva, right? That stuff's all autonomic, automatic. We don't think about it. Then for sensory, it transmits gustation, our sensation of taste, from the anterior 2/3 of the tongue. Okay, so it's involved with that process of gustation. Bell's palsy is due to inflammation of the facial nerve. We talked about that in the previous chapter. So, just due to the pathway in which that nerve is traveling through the skull and the face, it tends to just have an issue of inflammation, kind of unknown cause exactly why Bell's palsy becomes a thing. Usually, responds quite well to medication, so steroids just to reduce that inflammation. Most people recover and it's not an issue long term. Vestibulocochlear nerve. This involves 2 divisions, so vestibular division, cochlear division. This is really a sensory nerve. Vestibular division transmits sensory information for a sense of equilibrium, sense of balance. So that is connected with our vestibule and semicircular canals within the inner ear. And those are our equilibrium structures in the inner ear. The cochlear division innervates the cochlea, which transmits sensory information, right? So we have a sense of hearing. Glossopharyngeal nerve. Glosso means tongue. Pharyngeal, think the pharynx. So there's innervation of the posterior tongue and pharynx, as we can see here in this visual. This is a mixed nerve. So for sensory function, transmitting general sensory information and gustation from the posterior third of the tongue and pharynx, so the muscular tube at the back of our throat. This nerve also travels down the neck and it innervates or has connection to chemoreceptors within the carotid bodies. These are very responsive to chemicals within the blood, responsive to CO2 and O2 levels, and those in turn can regulate the respiratory rate. So if too much carbon dioxide accumulates in the blood, that's going to cause our respiratory rate to increase to eliminate that CO2 from the breath. Baroreceptors are also found in a similar location within the carotid sinus. These are stretch receptors or pressure receptors, and these will send information to regulate blood pressure. For motor function, there's motor innervation of muscles within the pharynx or associated with the pharynx, helps to elevate the pharynx during swallowing. Also, parasympathetic innervation to the major salivary gland, the parotid gland here, to produce saliva. Any injury or inflammation of this nerve is going to, of course, cause problems with swallowing due to where it's innervating structures, and also can disrupt taste since it is involved with gustation. Then we have cranial nerve 10, the vagus nerve, the wanderer, so to speak, the only nerve that extends beyond the head and neck. It's a mixed nerve, so for sensory, innervates the thoracic and abdominal organs for that internal sensory reception. Also is involved with those baroreceptors and chemoreceptors, as we saw along with the glossopharyngeal nerve. Gustation from the epiglottis, and proprioception from the larynx and the pharynx. Motor innervation is where it becomes a little bit more, evident or prominent. There's somatic innervation to the muscles of the pharynx and larynx to control swallowing, so voluntary control there in that aspect. And then for autonomic control, the vagus nerve is extremely important member of the parasympathetic nervous system, providing innervation to the heart, lungs, stomach, liver, spleen, kidneys, intestines, and controlling all of that automatic resting and digesting activities. So, normal heart rate, normal blood pressure, normal breathing rate, promoting bile production, food digestion, urine formation, and nutrient absorption. Right? The vagus nerve is providing all of that innervation for that parasympathetic division of the autonomic nervous system. For the accessory nerve, this one is really the oddball because it originates from outside the brain, begins as little rootlets coming from the spinal cord in region C1 through C5, and then it converges, loops into the cranium, then comes out here through the jugular foramen to innervate the sternocleidomastoid and the trapezius muscle. So some anatomists don't really consider it a true cranial nerve due to where it originates. So it really kind of is the oddball, but plays a really important role in innervating these neck muscles which move the head around. Then lastly, the hypoglossal nerve. So we can see here below the tongue, that's literally what that name means. It innervates the muscles of the tongue to manipulate food during chewing, contributes to swallowing, and allows for speech production. It's a very important nerve here. For spinal nerves, there are 31 pairs of these. More technically, 30 functioning pairs. The last one, tiny little coccygeal nerve, really serves no purpose in the body. So sometimes you'll see 30, sometimes you'll see 31. These are all mixed nerves, meaning they carry sensory and motor fibers. They're named according to where they emerge from the spinal cord, and they're innervating, all body parts except the head and neck, or parts of the neck. There's 8 pair of cervical, 12 thoracic, 5 lumbar, 5 sacral. Then again, that one coccygeal nerve, which really serves no function. When we think about the formation of the nerves, we need to go back and consider the spinal cord. And we talked about the gray matter and the white matter in the spinal cord and how, the ventral horn contains motor neurons, the dorsal horn contains sensory neurons. And we're going to see a similar thing here when we start to talk about these roots, which give rise to the spinal nerves. The ventral roots contain lower motor neurons and are exiting the spinal cord. Dorsal roots contain sensory axons. Also, there's a dorsal root ganglion, a collection of sensory neuron cell bodies. Those roots then blend together to form a spinal nerve, which is mixed due to the fusion of sensory and motor. Right? There's also going to be some autonomic fibers in there as well. Spinal nerves are very short, only about 1 to 2 centimeters, and then they quickly branch to form rami. So when we look at this visual here, here's our dorsal root, here's the ventral root coming together, here's the short little spinal nerve, then quickly branching dorsal ramus, and then here is a ventral ramus. So all spinal nerves are doing that, quickly branching. There's also sympathetic rami, which are going to contain autonomic fibers of the sympathetic division. We'll take a look at that in the next chapter. All right, but they quickly branch. Dorsal rami are going to innervate the posterior body trunk, ventral rami innervating the anterior body trunk, and form complex nerve plexuses, which innervate our upper and lower extremities. For the intercostal nerves, there is, very distinct branching, ventral rami, dorsal rami, and there's no complex nerve plexuses in this area. So the innervation just kind of wraps around the thorax, innervating that intercostal region. Versus we find these other spinal nerves are going to contribute either to a cervical plexus, brachial plexus, lumbar, or sacral. So again, rami or ventral rami, except the intercostal nerve, form these complex networks called nerve plexuses. And these pathways are really convoluted, they crisscross, and that's an important feature because each branch is going to contain fibers from several spinal nerves. So if there's damage to one spinal nerve, it won't cause complete paralysis or complete loss of function in that peripheral nerve fiber. This table really summarizes the general functions of each plexus. I indicate key nerves in each one. We're going to look at these in more detail in the upcoming pages, but it's always good to kind of come back and be able to summarize the thoughts and ideas here. So for the cervical plexus, it's controlling neck muscles, controlling the diaphragm, swallowing muscles, and the phrenic nerve is a really most significant one there that we'll talk about. Brachial plexus, control of the upper extremity. Lumbar and sacral is more to do with control of the lower extremity, along with other things as well. So here's a visual of the cervical plexus. As you look at this image, you can see there's just so much converging and diverging, mixing. It's just like a mess of fibers. But again, there's a lot of crisscrossing, ensuring that these peripheral nerves here, when they innervate a muscle, they're receiving innervation from many spinal nerves, several of these roots here. There's two nerves in particular that are quite significant: the ansa cervicalis, innervating muscles involved with swallowing and speech, and then the phrenic nerve is really the one that I want you to think about. This travels down the neck, goes into the thorax, it innervates our diaphragm, which is all to do with breathing, right? That's the primary muscle, the prime mover of inspiration. So, of course, this nerve is very important for us to be able to breathe. If there's any damage to the cervical region, right, any damage to the spinal nerves here, it could potentially cause respiratory failure if it damages the phrenic nerve. Hiccups occur when there is irritation to the phrenic nerve. This can happen when we overeat and apply pressure to the nerve where it's found within the abdominal cavity. That causes sudden closure of the glottis, the opening between our vocal cords, creating that hic sound that we produce. With the brachial plexus, this is providing sensory and motor innervation to the upper extremity. In blue here, it represents the roots or the ventral rami coming out of the spinal cord. These come together to form trunks, eventually form an anterior or posterior division, and then lead to the 5 major branches of the plexus. And that's the ulnar, median, axillary, radial, and musculocutaneous nerve. We can use arm to remember those 5 major branches. So again, we want to think about, why are these plexuses so complicated? Why is there so much convergence and divergence? Well, the convergence allows multiple spinal nerve roots to combine into one peripheral nerve, and this is a protective function. So, if one spinal nerve root is damaged, the other roots are still going to be able to contribute to the function of the nerve. And this really prevents complete paralysis or total loss of either sensation or motor function in a particular area. Divergence enables fibers from a single spinal nerve root to innervate multiple muscles or innervate multiple sensory locations. And this really enables the ability to coordinate multiple muscle groups and carry out real smooth functions. So this really enhances the limb's versatility. It provides a protection, protective barrier, and enables control. So here I have really provide brief motor function for each of these major branches. So the ulnar nerve, it's important for controlling intrinsic hand muscles. So the ulnar nerve being shown here, branching out, innervating the hand, controlling really fine motor activities. So writing, manipulating tools, sculpting, doing things with your hands. Median nerve innervates the anterior forearm muscles, so it's right in this middle region of the forearm. Innervation to those forearm muscles are going to cause wrist flexion, also play a role in pronation. Also branches off to innervate the thumb muscle for opposition. The axillary nerve, this one's a little bit of an easier one, shorter one. It just innervates the deltoid muscle as well as the teres minor. So it stays right in the armpit region, where near to where we would find the deltoid, right? Does not traverse further down the arm. Radial nerve innervates the triceps brachii for forearm extension, as well as the supinator and other extensor muscles of the forearm. Musculocutaneous nerve innervates our biceps brachii and the brachialis, right, for elbow flexion, as well as the coracobrachialis for complete arm flexion, moving the entire arm forward. So here you can see, there's very key muscles being innervated by these 5 major branches of the brachial plexus. There's many other small branches as well, innervating all the other muscles of the upper extremity and shoulder region. I'm not going to expect you to memorize all these, but what I think you'll realize as you look at the name, it kind of makes sense what muscles are being innervated by it. Dorsal, scapular. In that area, we're going to find the rhomboids, levator scapulae, thoracic nerve, closer to the thorax, the ribs. That's where we find the serratus anterior. Suprascapular nerve, okay, innervating the supraspinatus, infraspinatus, going through the suprascapular notch of the scapula. Lateral medial pectoral nerve, well, going to the pecs. Subscapular nerve, going to the subscapularis as well as the teres major. Thoracodorsal region or nerve, right? So in the thorax, in the back area, right, that's where we find the latissimus dorsi. So the names really kind of imply, where we're going to be finding that muscle it's innervating. And then along with that, we bring in the information from chapter 10. We can maybe remember function as well. So I don't want to neglect the sensory function of these nerves of the brachial plexus. I'm not going to make you memorize any of this, but I'm just showing you kind of a color code of these different nerves and where they're providing sensory
Injuries to the
information.
brachial plexus are quite common in relation to other areas, especially when the upper limb is pulled excessively. That leads to stretching of the plexus, and that can lead to damage to the nerve fibers within. This is especially true with newborns that need physical assistance passing through the birth canal. So when a baby is large and can't quite squeeze through, the physician may need to pull on the arms or even break the clavicles to kind of squish the baby and get them through the birth canal. We refer to that as Erb's palsy, and I'll talk more about it on the next page. Syndromes or conditions associated with median nerve injury are going to lead to a difficulty grasping between the thumb and index finger because the nerve is innervating the muscles associated with that. So, carpal tunnel syndrome is when there's compression of the median nerve as it travels through the carpal tunnel at the anterior carpal region or the wrist. Ape hand is another one that's due to a loss of thumb opposition. It causes the hand to be displayed in more of a ape-like, gorilla-like manner. Ulnar nerve injury, this one in particular is very vulnerable to injury. One associated condition is claw hand, so the inability to really extend the fingers very well. It makes more of like a claw-like appearance with the hand. These individuals also have trouble making a fist and gripping objects due to the loss of function in that area. Also, the funny bone is associated with the ulnar nerve, and not necessarily an injury, but if we hit the ulnar nerve at this particular area, it causes that funny sensation. So the ulnar nerve, it rests against the medial epicondyle of the humerus. So that's the bony knob you feel on the medial aspect of the elbow. And the ulnar nerve travels just underneath that epicondyle. And when we hit it just right on the table, especially on the edge of a table, it creates that funny bone feeling. Then for radial nerve injury, wrist drop is an associated condition, the inability to extend the hand at the wrist. Also crutch paralysis. So an individual using crutches can compress the radial nerve, cause some palsy in that area and discomfort in that area. Nerve compression refers to when a nearby structure puts pressure onto a nerve. And when we're thinking of a nerve and it has, many different fibers within, is usually the large diameter sensory fibers that are affected first. So there can be a loss of touch, pressure, and vibration. And then the small diameter sensory axons are usually preserved, not as impacted by this. So there's still going to be a sensation of pain, awareness of temperature, and autonomic functions are usually preserved. So it's more again, the touch and pressure, vibration associated with the larger diameter fibers. The symptoms of nerve compression are usually a sharp or burning pain, numbness, tingling, muscle weakness. One classic example is carpal tunnel syndrome, which I mentioned earlier. And this is compression of the median nerve at the wrist as that nerve passes through the carpal tunnel right under the carpal ligament. It can cause compression right in that area when there's overuse of the hand and wrist. And that can lead to weird sensations in this area of the hand or can cause the painful sensation there.
Erb's palsy is a type of paralysis that affects the arm and shoulder muscles, and this is due to an injury of the brachial plexus during childbirth. So, when a baby's too large, having a hard time passing through the birth canal, the doctor needs to pull on the head, pull on the shoulders, maybe even break the clavicle to get the baby out. This leads to damage to the upper trunks of the brachial plexus. This is actually something that happened to me when I was born. I was 10 pounds, 6 ounces, so they didn't think I was coming out. They actually broke my clavicle on the right side, and that left me with Erb's palsy. So my shoulder is kind of, dropped. Arm is like internally rotated, as you see in this image here. My arm's a little bit more, internally rotated. My wrist doesn't quite flex like shown in this image here, but this is a usual presentation with Erb's palsy. So it's also called waiter's tip because the arm is positioned in this way and the wrist will tend to be flexed as well. So like someone reaching back to receive money, from someone, waiter's tip. So it leads to weakness and inability to move the arm the same way as a normal arm, limited range of motion, may even have atrophy. So I don't have it too severely, but I have a really hard time supinating my arm, have a very hard time extending my arm completely. Putting my arms above my head is challenging on my right side. And I'm, naturally right-handed. I still write with my right because I have more fine motor control, but I do everything else with my left. And that's just something I've learned to do, of course, over time. Um, I don't know any different because, I've had this condition since birth, but it does kind of impact your ability to utilize your arm. To remember wrist drop, claw hand, and then ape hand and what nerve is injured for those conditions, you can use the mnemonic Dr. Kuma. So D for drop, R for radial, C for claw, U for ulnar, M for median, A for ape. That helps to keep those straight. So you'll see that with each injury, it's going to affect the hand in a different manner. Radial nerve injury, don't have that ability to extend the wrist, so it's dropped. Ulnar nerve injury, it impacts the pinky and the ring finger, inability to extend those well. So they're kind of making more of like a claw like appearance. And then ape hand, that loss of opposition, kind of making it look more like ape like, is the name that they give it.
Now moving to the lumbar plexus. This involves spinal segments L1 through L4. And here we can see the major nerves which make it up. I'm going to talk briefly about most of these. We're not going to worry about too much detail. One of the most significant ones is the femoral nerve because it is the largest in the lumbar plexus. It also has many branches that come off of it. So we look at this image here. Right at this point, we see the femoral nerve, and then you can see it quickly branches, giving rise to many other peripheral nerves. This table summarizes the functions of the iliohypogastric, ilioinguinal, genitofemoral, lateral femoral cutaneous nerve. And just by focusing on the name of them, it may help you to kind of think about innervated structures and general function. So, ilium, right? Think of your coxal bone, the bone you feel at your sides, hypogastric, lower stomach area. This is providing sensory information or receiving sensory information from the gluteal region as well as the pubic region. For motor control, it's the transverse abdominis and internal oblique. We're going to see the same motor control coming from the ilioinguinal nerve as well. So, guinal here, think groin, sensory information from the groin. That's going to vary for males and females in terms of, what those structures are. But again, guinal, groin, sensory coming from that area. Genitofemoral, sensory to the genitals. So the scrotum of males, the mons pubis and labia of females, right? The groin area where the genitals are being found. Lateral cutaneous, anytime you see cutaneous, think of skin, sensory information from that area, the lateral side of the
For
femoral
the femoral
region.
nerve, this is the largest nerve in the lumbar plexus. For motor branches, it innervates the quadricep, sartorius, pectineus, and iliacus muscle. So involved with flexion at the hip, but also extension at the knee. We have cutaneous branch to the anterior thigh, or what's referred to as the intermediate cutaneous nerve of the thigh. We have an articular branch that provides proprioception to the knee, also a vascular branch for the major artery, femoral artery in that area. One of the most significant branches is the saphenous nerve, which provides sensation for the medial leg all the way down the leg and even to the foot. So make sure you understand how there's like this major motor branch, especially to our quadriceps, right? That's a big one. And then there's a lot of sensory here as well. The obturator nerve passes through the obturator foramen of the coxal bone. For motor innervation, we have the adductor muscles, brevis, longus, and even magnus, as well as the gracilis. So these are the major hip adductor muscles, right? Providing a lot of motor innervation there. And then there's also a sensory cutaneous branch for the skin at the medial thigh.
Then for our sacral plexus, here are the major branches. The most significant one being the sciatic nerve because it's the largest nerve in the body. It's really thick, about 2 centimeters in diameter. So here's a visual of it there. It branches to form a tibial nerve and common fibular nerve. And, there's many other important nerves here as well. We'll talk about the pudendal nerve and briefly mention these other ones as well. So this table summarizes the function of these major branches. For the sciatic nerve, I want you to remember that for motor innervation, it goes to the hamstrings. Also playing a role in sensory functions, so skin of the foot, leg, part of the thigh. Pudendal nerve is really important for bladder and bowel control. So it provides motor innervation to the pelvic floor muscles, external urethral sphincter, controlling urination, external anal sphincter, controlling defecation, right? We really want to be able to have motor control there. Pudendal nerve is providing that. Similarly, sensory innervation of the external genitalia, the anus, and the perineum. So all of those sensitive private areas there, all provided by the pudendal nerve. You can see these other ones being listed, not that I want to neglect them per se, but gluteal nerve going to the glutes. There's a cutaneous nerve. There's a piriformis nerve going to the piriformis muscle, allowing for lateral leg rotation, and many others as well, but focus mostly on the sciatic and pudendal nerve. Elaborating on the sciatic nerve, as I mentioned, innervating the hamstrings, it divides into the tibial nerve and common fibular nerve or perineal nerve. Those two nerves then do a lot of different things, but really to summarize, the tibial nerve allows for plantar flexion because it innervates the gastrocnemius, the soleus, tibialis posterior, along with toe flexion. Common fibular or perineal allows for dorsiflexion and toe extension, along with ankle eversion. So notice how really controlling the opposite muscles, doing the opposite functions here. Sciatica is inflammation or injury to the sciatic nerve. This causes radiating pain or numbness down the entire leg. Very common thing that people deal with. I struggle with it sometimes, especially when I'm sitting down for too long period of a time. So when I'm making PowerPoints on my laptop and I'm making video lectures, right, and I'm just sitting in that, flex position too long, it starts to irritate my sciatic nerve. A lot of other reasons, why it could occur, but due to its location, right, it causes that radiating pain. One common cause of sciatica is called piriformis syndrome, when this piriformis muscle compresses the sciatic nerve. This is being labeled right here. When it contracts, it allows for a rotation of the leg at the hip, and just sometimes it gets kind of irritated or it can spasm. So it's important to do these different stretches here as shown to help alleviate discomfort in that area. Dermatomes are areas of skin supplied primarily by a particular spinal nerve. These dermatomes have been mapped out along the body. It's a predictable region of skin. These dermatomes can be tested for touch. So you can apply light touch, you can apply more of a sharp touch to these dermatomes. And that becomes clinically significant because it helps to identify location of nerve injury or even spinal cord injury. So dermatomes become really important for, physical therapists when they're identifying injury and what you can do to help treat that. Similarly, myotomes are groups of muscles primarily innervated by motor fibers of a single spinal nerve. So each, spinal nerve is going to be more dominant in a particular muscle group, going to be controlling a specific muscle movement. And these myotomes are also clinically significant in assessing, diagnosing nerve injury, spinal cord injury, right? You want to be able to evaluate sensation. You also want to be able to evaluate motor function. So each myotome is going to be controlling a particular thing. So just as an example, C5, that particular spinal nerve is primarily involved with shoulder abduction, right? Then you look at, say, L2, hip flexion, so on and so forth. So a physical therapist can have a patient do these particular activities, assess whether or not there's deficiency that may indicate in damage to one of these particular spinal nerves. Now we need to consider reflexes, which are involuntary, nearly instantaneous movements of the body in response to a particular stimulus. These function without input of higher brain centers, and they involve reflex arcs that can stay entirely within the spinal cord or entirely within the brainstem, so it does not have to go up to the cerebral cortex before initiating a motor output. Reflexes in general are important for maintaining posture, balance, protecting us from harm, but also maintaining homeostasis. So we can classify the reflexes as either somatic or autonomic. With the somatic, it has to do with control of our skeletal muscles, versus autonomic, it would be things like the pupillary light reflex we talked about, baroreceptors adjusting blood pressure, gastrocolic reflex, just that automatic activity of the gastrointestinal tract after we eat. So there's a lot of autonomic reflexes, which, are controlling general body homeostasis, where the somatic becomes more important for posture, balance, protection from harm, and things of that nature. A reflex arc is a neural pathway that involves a sensory neuron and its receptor, right? Sending that information to the spinal cord or brainstem. That's going to synapse with an interneuron, being the integration center, which then directly synapses onto a motor neuron and then an effector cell. So, a particular stimulus can activate this reflex arc and cause an automatic response without sending that information up to the brain for processing. So, this makes a really fast, quick response, right? Because you don't have to waste the time with sending the information to the brain. The muscle spindle, one of the proprioceptors, controls the muscle spindle or stretch reflex. It's a rapid protective response, helps to maintain tone, posture, balance, and can also, importantly, protect muscles from excessive or sudden stretch that could result in damage. So there's particular areas within the muscle containing this spindle of sensory fibers, always being sensitive to the degree of stretch within the muscle. When the muscles are contracted and the fibers are sliding across one another, this actually does not stimulate the muscle spindle, so there's no action potentials being produced. First, in a relaxed state, this blue sensory fibers of the muscle spindle, slightly activated so that it knows that the muscle is resting and relaxed. So there's a steady stream of action potentials going to the brain. Versus when the muscle becomes stretched, that further activates these sensory fibers, and there's going to be a higher frequency of action potential sent to the brain. But when there is a quick stretch in the muscle and a quick activation of this muscle spindle, it can trigger a reflex, which will then contract the muscle to relax it and prevent excessive stretch of that muscle. So, the knee jerk reflex is the classic example of the stretch reflex. When someone taps on the patellar tendon with a reflex hammer, that, of course, is hitting the tendon, but it's quickly pulling and stretching the quadricep muscle. That activates the muscle spindle within, initiating this reflex arc. So, blue being our sensory neuron, green being an interneuron. We see two different motor neurons involved with this. One of the motor neurons is going to the quadriceps to cause contraction, to prevent excessive stretching of the muscle. The other motor neuron is going to the hamstring, the antagonistic muscle group, for further enabling that knee extension or further enabling the quadricep to contract. So the whole goal here is to prevent that excessive stretch of the muscle. With Golgi tendon organs, these are located within the tendon or really at the junction of muscle and tendon. So they're sensitive to tension within the tendon. So this is especially true when a muscle is contracted and is pulling on its tendon. So this is always sending proprioception information to the CNS. Then the brain can make fine adjustments if needed to really, enhance motor control, enhance precision. But there's also times in which if there's excessive tension on the tendon, it will trigger the Golgi tendon reflex. So the goal here is the same, in which is trying to provide protection, but the way in which it does it is different. This reflex actually causes the muscle to relax in response to excessive stretch to prevent tearing or injury to the tendon. We also have a flexor or withdrawal reflex. This is very protective, very critical for survival. It's initiated by painful or harmful stimuli, right? We don't want to stick our fingers into a tiger cage if they come at us, right? We're going to quickly withdraw it. We don't want to get our fingers bitten off. Just like if we, touch a painful stimulus, such as a nail or a pin, there's an automatic withdrawal of that threatened body part. This is polysynaptic, meaning there's quite a few neurons involved in this circuit. Many different muscles could be activated depending upon the stimulus, location, yada yada. With conscious effort, we do have the ability to override this, right? We can kind of like force ourselves to be in harmful situations. So, the brain can provide input, but a lot of times this just kind of automatic withdrawal occurs more on a subconscious level. Along with it, we have a crossed extensor reflex, which is protective, balance maintaining. It's going to occur alongside the withdrawal reflex, especially when we think about the lower extremities to maintain balance. So with this example here, say we're walking along the beach, we have our right leg here and we step on a piece of glass. We're going to have automatic withdrawal of that limb due to the painful stimulus, but we're also going to have crossed extension of the opposite leg to provide stability and to prevent falling over due to that sudden movement. Sometimes it works, sometimes it doesn't. Maybe you fall over, right? But it's kind of two things all at once, a withdrawal reflex as well as this crossed extensor reflex. This, of course, is polysynaptic as well, meaning involving several neurons, several synapses for this reflex to take place. Then lastly here, I'm going to briefly talk about nervous tissue damage. And this is serious because most mature neurons are amitotic and cannot regenerate. There's a lot of different things that could lead to nervous tissue damage. Could be traumatic, a laceration or a cut, concussion, an accident in a vehicle, right, can really damage the nerves or even the spinal cord. It could be ischemic injuries, so a stroke or a cerebrovascular accident. That's when there is a reduction in blood flow to the brain, reduction in blood flow to even nerves that can cause cell death, brain impairment, inadequate control of the body. There's a lot of neurodegenerative conditions, multiple sclerosis, ALS, Alzheimer's, Parkinson's disease. I'm not making you remember any of these in A&P. If you go on to take like a pathophysiology course, you'd need to know that in more detail. Inflammation or infection, so meningitis, inflammation of the meninges, encephalitis, be inflammation of the brain. Metabolic or toxic damage. One common one is diabetic neuropathy. I'm going to go into a little bit more detail on the next page about that. And then we can see some other examples being listed as well. So diabetic neuropathy is a type of nerve damage in diabetics due to the direct effect of chronic high blood glucose on peripheral nerves. So if someone has uncontrolled diabetes for a long period of time, it causes damage to these nerves in the extremities. So over time, there's going to be a reduction in sensation, numbness, even pain, weakness to the muscles, and in real severe cases, it can lead to amputation. due to a loss of sensation and unawareness of injuries to the feet in particular. So someone that's diabetic, they might, just go trim their toenails and accidentally cut it way too deep, right? It'll start to bleed, create an injury. Well, it may not even really hurt. They may kind of end up neglecting that cut, not taking care of it. It could become infected. Healing is decreased in these individuals as well. It could lead to infection spreading throughout the foot, and then again, severe cases, amputation of the limb. But it's honestly quite common. So you've maybe already made that association of diabetes and amputation, and it's due to this neuropathy that occurs. Prevention is really key, the most important thing. Managing the blood sugar is going to be really important for preventing injury to the peripheral axons. For regeneration of nerve fibers, the only part of the neuron that could regenerate is the axon if the cell body is intact, and it's only axons of the peripheral nervous system. Regeneration is carried out by the Schwann cells. However, it is limited, it's not going to be perfect. Paresis or muscle weakness or paralysis, loss of motor control, and even loss of sensation may still occur. Axons of the CNS cannot regenerate. It will not happen. Oligodendrocytes produce growth inhibiting proteins, and this is really just a protective barrier against, tumor formation and cancer production, right? So the CNS will not regenerate if there is neuron damage. So that's the end of chapter 13, the peripheral nervous system.